I welcome all master faculties and guests for this today's presentation. This presentation on the management of pulmonary hypertension and fibrosis and the cytokine production in COVID-19 patient. Before we start for today's presentation, I'd like to introduce the MSN. MSN, innovation resonates a sense of purpose in the evolution and existence of human life. The creative capacity of a human mind has always been a source of inspiration. We believe every life matters and everyone deserves a quality medicine. Apart from the efficacy, affordability, and accessibility, we want to be the first to touch and impact human life. We are MSN. MSN, Research for Better Medicine. The quest for innovation drives us to serve better and better today and tomorrow. One of the Asia's largest integrated pharmaceutical API and formulation R&D centers we have, that is in Hyderabad. And because of that we have the global presence. Meet the global Indian pharmaceutical company. Our global presence, turnover crossing $600 million USD, presence in 65 countries globally and 8 offices worldwide, including US and UK, 11,000 workforce in globally, own the trust of more than 4 crore customers across 65 countries, and integrated state-of-art R&D centers and 14 manufacturing facilities in India and USA. Thus making Tricolor proud, research for better medicines. The Indian spirit, making Tricolor proud. MSN having more than 250 plus product in pipeline, 100 plus ANDA submitted in US, 600 plus patent globally, 25 products approved in US, 715 world largest DMF we have filed in the US. Not only, sir, we have 17 products commercialized in US also. Thus makes many products to launch first time in India. Our first time in India launches include, in 2013, we have come with the Prasugrel, Febuxostat, Tapentadol, Tolvaptan. Then 2015, we have come with the Bosentan. That is one of the medicine used for the pulmonary hypertension. Then we have the Roflumilast, Vilisadone, then Loracidone we have launched in 2016. Then come in 2017. 2017 we have come with the new molecule, that is the Ambrisentan for the management of pulmonary hypertension, Nesitantan for the management of pulmonary hypertension. Then we have brought the Riociguat to the Indian patient. And 2020 we have brought Trentine. And in 2021 we have brought the brand molecules like Dapagliflozin, Sacubitril Valsartan, the brand like Dapavan, Sacuten, Tofaros, and the Revanex. Partner in practice, MSN expertise in the research to innovate brought us first time India launches to support super specialists in bringing down Indian patient suffering. Who to better stand by you, a company with a global research, global manufacturing, and global quality. Company which has acquired trust globally. We at MSN on a journey to serve you better and better. To partner in creating awareness in the management of pulmonary hypertension, pulmonary fibrosis in COVID-19 patients, approach for the emergence treatment option that to increase patient life expectancy and quality of life. So we are associating with you for pulmonary arterial hypertension management. For today's program, before we start the program, we'd like to introduce our today's moderator, Dr. Vikas Kohli. Dr. Vikas Kohli is Director, Delhi Child Heart Center, highly skilled and experienced non-invasive and interventional and fetal cardiologist with the American board certificate. Dr. Kohli has done the cardiology in the University of the Miami, Jackson Memorial Hospital, Florida, USA, and pediatric residence. Dr. Kohli presently heading the director in Delhi Child Heart Center in New Delhi, India. Dr. Kohli is also associated with the functioning in various professional bodies related to the pediatric cardiology. He has got the Best Research Award in University of Miami and Florida in USA. He got the Best Fellowship Award from American Heart Association and American College of Cardiology, Travel Fellowship. He has the American Board of Certified Pediatric Cardiologists. He has an expert online eco training closer and follow pediatric cardiology supervisor. Examiner on the final fellowship exam in pediatric cardiology. He has an expert intervention pediatric cardiology and non-invasive pediatric cardiology. He has an expert in fetal cardiology and the complex fetal diagnosis. He is expert in the management of complex heart disease and pediatric cardiac intensive care unit. So, Dr. Kohli, now I'd like to hand over the session to you.
Thank you very much for the flowering and the flattering introduction Mr. Mandal, and I was very impressed with your presentation of MSN also as an international company. If you will allow me, I will go ahead with the first presentation today, and I would like to share it. So we'll be talking about pulmonary hypertension and COVID-19 infection. And pulmonary hypertension, as we all know, is basically small pulmonary arteries less than 50 microns, which get affected by vasoconstriction, medial hypertrophy, cell proliferation, fibrosis, and finally there is complex lesions like plexiform formations and thrombosis inside C2. The mean pulmonary artery pressure in these patients with PAH is more than 25 millimeters of mercury, wedge pressure less than 15 millimeters of mercury, and the pulmonary vascular resistance is more than 3 Wood units. What are the statistics? First of all, on the right side, there is classification of pulmonary hypertension. Group 1 is pulmonary arterial hypertension, most common being idiopathic, and this is what we would see in the adult population as the most common etiology. Hereditary, which is genetically related, congenital heart disease is included in this. Group 2 is pulmonary hypertension due to left heart disease, which we see in a significant number of patients with diastolic dysfunction in adult heart disease, especially related to LV dysfunction or due to hypertension. Pulmonary hypertension due to lung disease and or hypoxia is chronic obstructive pulmonary disease, sleep disorders, interstitial lung disease, which Dr. Ankit will be talking about and is a specialist in, and chronic thromboembolic pulmonary hypertension, multifactorial pulmonary hypertension. Now, the incidence ranges from 1 to 2 cases per million. And the pH affects both, pH affects both males and females, and finally results in right heart failure and death. The median survival of patients after diagnosing PAH is 2.8 years from the time of diagnosis. 3-year survival is 48%. Currently available therapies, only 58 to 75% of PAH patients survive for 3 years. PAH may occur in isolation or along with other conditions, as we have mentioned in the classification. Now, coming to the focus of today's discussion, COVID-19 infection, pandemic, and its relation with pulmonary hypertension. We all know the magnanimity of this problem, and all of us are facing this. And I pay all my respect to each one of you and your family and relatives who may be affected or are vulnerable by working in the medical field, and I hope everyone remains safe. 86% of critically ill COVID-19 infected patients have heart failure and chronic kidney disease as the most common underlying medical conditions. It primarily affects the respiratory system, and the endpoint of respiratory involvement is ARDS. COVID-19 possesses mechanisms that promote the pathogenesis of pulmonary arterial hypertension. Histologically, patients who died of COVID-19 exhibited thickened pulmonary vascular walls. This is an important hallmark of arterial hypertension itself. Few individuals who were previously infected with COVID-19 had tendencies to develop pulmonary arterial hypertension. And increased susceptibilities to develop PAH may occur only in patients who survived severe COVID or those who developed mild or even no symptoms in response to COVID infection. These patients are susceptible to develop PAH. I would like to highlight that. So, as stated earlier, COVID-19 can lead to development of pulmonary arterial hypertension, but even PAH patients, pre-existing pulmonary hypertension patients, are vulnerable to COVID-19 infections. PAH is associated with high mortality in itself, but, and here is the stunning fact, PAH and or its targeted therapies might be protective against COVID-19, which is why majority of the PAH patients, when they get COVID-19 infection, it is not a severe infection. Thus, the number of COVID-19 cases reported amongst PAH is surprisingly low. Anecdotally, PAH centers in areas hit hard by the pandemic were not observing as many patients with PAH with COVID-19 as they had anticipated. Now, why all this is happening? Why PAH therapies might be protective for these patients? It has been hypothesized that physiopathological features of PAH and the benefits attributable to specific treatments might lead to protective effect through the following mechanisms. Number one, reduced viral entrance. We all know that ACE2 receptors are the ones through which the virus unlocks and enters a cell. So what do these therapies do to these receptors? We will come to that in a moment. And the role of chronic inflammation in pulmonary arterial hypertension. That is, in underlying PAH, there's already an immune mechanism. Does that mechanism predispose a patient to counter the effects of the virus? Second is attenuated lung damage. Third is protective effects of the therapies. So now let's first talk about reduced viral entrance. The ACE2 receptors in PAH patients' blood and lungs, the ACE2 expression is decreased. If the expression is decreased, the number of viruses which can bind to cells with these receptors become low in number. The low ACE2 levels in PAH patients could act as a protective factor. Role of chronic inflammation in PAH. In PAH patients, chronic pulmonary inflammation is a common immune cell type such as lymphocytes, macrophages, neutrophils infiltrate the lung. This is in a patient who already has PAH and then is exposed to COVID-19. Their lungs have a chronic pulmonary inflammation due to PAH itself. And this is the adaptive immune system from immune cellular landscape. And thus, tertiary lymphoid tissue is present in the vicinity of bronchioles, which hypothetically is limiting the viral infection and expansion. Now, next mechanism we are talking about is attenuated lung damage. Changes in lung perfusion, unusual dissociation between lung mechanical properties and severe hypoxemia has been reported, which means abnormal hyperperfusion of non-ventilated areas as a consequence of impaired lung perfusion regulation. The basal abnormal lung perfusion present in PAH patients could limit this abrupt perfusion imbalance towards non-ventilated. So to simplify this complicated language, that in COVID-19 there are certain changes which happen. But in the changes which happen due to PAH in the lung itself may actually be countering the effects of the COVID-19 virus effects on the lung perfusion and the hypoxemia. Furthermore, chronic vasodilator treatment could prevent a severe hypoxic vasoconstriction response, and phosphodiesterase inhibitors and calcium channel blockers have been proposed as a potential treatment for COVID-19 based on their vasodilation properties. So protective effects of endothelin receptor antagonists, ERAs, against ARDS. This is the third mechanism which may be protecting PAH patients in the scenario of COVID-19. PAH targeted therapies could have protective effects against COVID-19, improving endothelial function. So here specifically the ERAs work on endothelial function. ERA stands for endothelin receptor antagonists, incidentally, so that they work through the endothelin receptors and endothelial function. ERAs inhibit angiotensin II, induced vasoconstriction and lung injury, and this is upregulated in PAH. Endothelin receptor antagonists could be beneficial in treatment of COVID-19 lung injury, enhancing the nitric oxide pathway, commonly used PAH targeted therapeutic avenues. Now, nitric oxide and the role of prevention and treatment in COVID-19, we all have heard about that possible study from Lancet included, but we are not going to focus on that right now. But here is where nitric oxide also comes into the picture. So admission of PAH patients to negative pressure rooms in ICU and a trial of non-invasive ventilation or high flow OptiFlow as a reasonable approach to these patients, management in the ICU as the initial treatment may be the right way to go about it. Centers which have facility for inhaled nitric oxide or inhaled epoprostenol, these should be considered, but in India, epoprostenol is a drug which is not available unless MSN decides to have it available for us over a period of time, and inhaled nitric oxide is available in few hospitals in the country. If intubation is inevitable, goals of care should be established. Preferably, goals of care should have been established before reaching this point, and these should include, the role of lung transplant also. Hypotension and loss of RV contractility may be prevented. Administration of inotropes, catecholamines, fluids should be considered before anesthesia. Etomidate is preferred for inducing general anesthesia. And in a critically ill PAH patient with COVID-19 infection, continue PAH-specific therapies, that is ERAs, etc., and phosphodiesterase inhibitors. Inhaled epoprostenol, iloprost can be used, and treprostinil can also be used. Endothelin receptor antagonists can be crushed and delivered via nasogastric tube. And patients on oral treprostinil should go on IV treprostinil, and patients on oral selexipag can briefly transition to IV selexipag if needed. Now on this slide, management of critically ill patients, continuing treatment with investigational therapies of COVID-19 have to be given. Systemic anticoagulation may be considered as a lower threshold to use when patients with PAH get COVID-19 infection. ECMO support when right heart failure takes the predominant scenario should be considered when organ transplant is not considered an option for COVID-19 infected patient. ECMO for PAH patients with COVID-19 may be an unjustifiable use of resource, which means that if you don't have a backup of heart-lung transplant or lung transplant, giving a PAH patient with COVID-19 ECMO as an option should not be considered. So, management of non-critically ill patients, hospitalized PAH patients, hypoxemia leading to hypoxic pulmonary vasoconstriction, which increases pulmonary vascular resistance, resulting in decompensation of high-risk PAH, performing chest CT and ECG at the earliest, maintaining saturations above 92 if at all possible. The baseline saturation in such a patient with PAH could be actually in the 80s. Continue oral parenteral therapies, and HCQ as azithromycin, convalescent plasma, tocilizumab, and others with remdesivir or ribavirin may also be practiced, which we are all aware of. I'm sure everybody in the audience is already aware of these. Management of non-critically hospitalized PAH patients, pulsed inhaled nitric oxide delivery systems, inhaled nitric oxide, beneficial effects on COVID-19. In low-risk patients with mild illness, brief interruption of inhaled treprostinil therapies should be considered, and in high-risk patients, parenteral should be considered. Meanwhile, needless to say, we all have to practice the three basic things, and the take-home message here is COVID-19 possesses mechanisms that promote the pathogenesis of PAH, and that some individuals infected with COVID-19 become susceptible to developing clinically significant PAH in the future. They have to be monitored for this. And I would also like to add to this take-home message that if a PAH patient, pre-existing PAH patient, gets COVID-19 infection, he's likely to be protected in more than one ways, which are internal mechanisms, immune mechanisms, and drugs which he's already taking. Thank you very much. I think the question and answers would be at the end of this session. I see Professor Chabra is here. Good evening, Professor. How are you?
Good evening.
Yeah, welcome to the meeting, and I'm waiting for your introductory slide to be uploaded by Mr. Tonmoy, and it would be my privilege to introduce you to the audience. We have a huge audience, and they are ready to listen to your talk. So Professor Chabra is the head of Department of Pulmonary, Sleep and Critical Care Medicine at Primus Super Specialty Hospital. He has completed his MD in Pulmonary Medicine from the Vallabhbhai Patel Chest Institute in 1986. He is presently heading the esteemed Department of Pulmonary, Sleep and Critical Care Medicine at Primus Hospital in New Delhi. He is associated with the functioning of various professional bodies related to pulmonary, sleep, critical care medicine, and he has been active in several areas of research, both basic, applied in the discipline of pulmonary medicine and allied sciences. He has carried out more than a dozen research projects from ICMR, DST, and CSIR, was awarded the Von Perquet Prize of the Indian College of Asthma, Allergy, Applied Immunology. He was also awarded the Fellowship of the American College of Chest Physicians, National College of Chest Physicians, Indian College of Asthma, Allergy, Applied Immunology. He has supervised several research projects, 25 MDs, and several PhD students have been co-supervised by him. He has delivered more than 150, and I guess that must be multiplied by 10 by now, and over 140 publications in prestigious indexed international and national journals. He has authored more than 20 book chapters, reviewer of several national international journals, editor of Indian Journal of Chest Diseases, Allied Sciences, associate editor of Journal of Indian Journal of Asthma, Allergy, Applied Immunology, and section editor of Lung India. He is a member of several committees of the Department of Government of India on various health issues. It's an honor to have you, sir, here, and we look forward to your talk. Please go ahead and share your talk.
Thank you for this kind introduction, Dr. Kohli. So I'll just share my screen and then get started.
Yes.
I hope the slides are seen by all. Okay.
Yes, sir.
Moving from the other aspect of COVID-19, Dr. Kohli has covered pulmonary artery hypertension. Another sequel of COVID-19 is pulmonary fibrosis, which in a way is also linked to pulmonary hypertension. We know a little bit about pulmonary fibrosis, but not enough to say that we can start treating pulmonary fibrosis. It's all in the stage of hypothesis formation, and we don't have actually any drugs specifically for post-COVID fibrosis, and we are repurposing drugs for other fibrosis to COVID. Now, COVID, as we all know, is one of the most devastating illnesses which has ever struck mankind. That doesn't require any repetition. We're having millions of patients so far in the globe, and we have waves of COVID. We had the first wave, out of which we came out fairly successfully, but the second wave has really struck us, has climbed steeply, and today we are having more than 3 lakh cases every day in India. So it's a tremendous burden on the population, not only in India but globally. Now, COVID-19 as a disease doesn't have a uniform prognosis. Majority of patients have a good prognosis. In fact, there will be many patients who may not have any symptoms at all. They get infected, the virus doesn't produce any symptoms, they recover without any sequel. And it has been estimated that almost 80% of patients with COVID-19 will only have mild symptoms of fever, cough, just like any common cold or upper respiratory tract infection, and they would recover from this. The problem comes with the remaining 20% who would develop substantial hypoxemia, which requires hospitalization, and out of those, another 5% who would have a high risk of mortality. So it's the high case fatality rate which is causing concern. If it was only a cold, one wouldn't really bother. So it's the high case fatality rate which is a matter of concern. And the deaths that are occurring are in huge numbers. Now, those who do not die, successfully treated with whatever treatments we have, they may not stage a full recovery. Lung may continue to have a damaged existence. So there is a morphological damage, and that is where the pulmonary fibrosis comes in. So patients who have had significant lung damage because of COVID infection, COVID pneumonia, they are left with pulmonary fibrosis, which may vary in severity from mild to very extensive one. And that is the challenge for the future, so that it's not over with the acute treatment of COVID. 2 or 3 weeks of treatment doesn't mean that we have beaten COVID. A substantial number of patients would continue to have long-term effects of COVID, and these are the long COVIDs or long haulers. This we have known from previous lung damage diseases like ARDS also. That is, one acute episode doesn't mean that the patient has recovered fully. So patients will continue to have sequelae, which would vary from mild fatigue or body aches to more severe forms, including damage to lungs, which would require oxygen therapy. Some would also be candidates for lung transplantation, besides other significant abnormalities related to heart and the cerebrovascular system, which I am not here. So ultimately, a large number of patients who today are getting COVID-19, we expect that in future they'll have an impaired quality of life. And a major cause of this would be pulmonary fibrosis. So pulmonary fibrosis is one of the complications which we are dreading. Even if 2 or 3% of patients end up in severe COVID, the numbers are so huge that the patients who will be left with pulmonary fibrosis and consequently have impaired quality of life, impaired functional capacity in their day-to-day living activities. So that number of patients with impaired activities would be huge. The radiological manifestations of fibrosis, these are obvious as early as the 3rd week after onset of symptoms. And this is regardless of severity of the acute illness. Even patients with mild to moderate degree of COVID pneumonia, they do develop some bit of fibrosis, although it's small. And greater the severity, greater is the risk of developing large areas of fibrosis. In fatal cases of COVID-19, organizing diffuse alveolar damage, that is a pathological hallmark of pulmonary fibrosis of varying severity. And a lot of information has come to us from the autopsy studies carried out in COVID-19 patients. Who is likely to get pulmonary fibrosis? Patients who have got an advanced age, very severe illness, males, patients with comorbidities like hypertension, diabetes, obesity, patients who go on to mechanical ventilators, patients requiring long period in ICU for their recovery, habits like alcoholism and smoke. So these are some of the risk factors which are hypothesized as being important determinants of pulmonary fibrosis. By no means proven, but this is the starting point, and these are the patients in whom we are watching closely on follow-ups where they are developing fibrosis. Now, the pathogenesis of fibrosis starts with inflammation, and I won't be covering this in detail. The fibrosis that follows inflammation is part of the general repair. We would remember from our lessons in general pathology that inflammation is followed by repair. But when this repair is out of control, when it is fibrosis, then that becomes a new disease. We all get injuries, there is a scar formation, and that doesn't progress. So it's the end of the matter. But if the scar formation becomes progressive, and there is reason to believe that in some patients, at least there is a biochemical basis for this fibrosis to be progressive. So if fibrosis is going to be progressive, then that creates a problem that one disease, COVID-19, has triggered off another disease, that is progressive fibrosis. So that is why use of antifibrotics is very much being considered in management of pulmonary fibrosis, identifying patients who are likely to develop progressive fibrosis. These are early days yet, we don't have any therapies, lots of hypotheses, many medicines are being tried. And these include antivirals, Chinese medicine, plug-in activators, spironolactone. All these are tried on the basis of some hypothetical evidence, some supportive evidence. 2 drugs which are especially receiving attention include pirfenidone and nintedanib. Now, these two drugs are approved for treatment of progressive pulmonary fibrosis. We have got idiopathic pulmonary fibrosis as a prototype disorder of progressive chronic fibrotic disease, and then there are other interstitial lung diseases which do have a progressive fibrosing phenotype. So for both of these, pirfenidone and nintedanib have been approved, and these have clearly been shown to have a favorable impact on lung function decline. These would not reverse the established fibrosis, but they would slow down the progress of the fibrosis. So that is the plus point that is there now in our therapies for idiopathic pulmonary fibrosis, for which we earlier did not have any treatment. So these drugs, having been proved to be effective in idiopathic pulmonary fibrosis and other progressive fibrosing phenotypes of ILDs, so there is a theoretical basis at least to try these drugs to halt the progressive fibrosis if it exists in COVID-19. For COVID-19, while new drugs are being developed, because it caught us off guard, so there have been a lot of old drugs which have been repurposed for this purpose. And pirfenidone and nintedanib belong to this class of drugs. That is, we are extending established use of the drugs in some other entity on a theoretical basis to COVID-19. Now, why antifibrotics in COVID-19? Lung pathology in COVID-19 can be diverse. It involves several parts of the lung. It involves the interstitium, involves the distal pulmonary vasculature, the alveolus, and the peribronchial tissue. And especially those patients who have had a severe course or who have died, significant lung fibrosis has been shown. This has come from autopsy studies. And the CT picture, this has a stark resemblance to an established interstitial lung disease. So therefore, it is obvious that we have to think in terms of fibrosis being an important part of pathology of COVID-19. And with this background, there is a growing enthusiasm to study antifibrotic therapy for COVID-19. And there are clinical trials underway using the currently approved antifibrotics. Pulmonary fibrosis, which follows COVID-19, this may have a progressive course, and there is a theoretical basis, especially with the involvement of cytokines like TGF-beta1 and the vascular growth factors. These may be leading to a progressive fibrosis. And drugs like pirfenidone, these are having an action on cytokines like TGF-beta1 and various vascular growth factors. So therefore, these drugs could inhibit the runaway fibrosis in COVID-19. So that is the theoretical basis why pirfenidone and a similar drug nintedanib has been proposed, that these might exert potential benefits in the prevention and treatment of pulmonary fibrosis following COVID-19 infection. And it has been suggested that we could use antifibrotic therapy, although these drugs do not form part of any guideline till now. And it has been suggested that if at all these have to be used, and these should be used in a clinical trial mode. The reason is that there is a theoretical basis, no proven role, so these do not enter into any guidelines, but we expect that antifibrotic therapy may improve oxygen saturation, may slow down the progression of fibrosis, may slow down the decline in lung function, may improve long-term survival in these patients. Nintedanib is also an antifibrotic drug. However, there is a concern that the coagulopathy that exists in COVID-19, one has to be cautious using nintedanib, because nintedanib is also known to be associated with increased risk of bleeding. So that way, pirfenidone probably has a safer profile where application COVID-19 is concerned. Now, how has this knowledge evolved in COVID-19? When it started, we did not have any treatment. And initial treatments started by discussions on social media, anecdotal case reports, personal experiences. At that time, there wasn't much evidence. Later on, studies have been carried out. We have had updated guidelines from National Institute of Health, from European Respiratory Society, from Government of India, so that at present, we have a sufficiently well studied and evidence-based management plan for COVID-19. So therefore, the scope for liberties which one could take in the early part of the COVID-19 pandemic, that one is not supposed to take. So if at all one wants to try new medicine, then it has to be the clinical trial mode, and one needs to follow evidence-based medicine. The current treatment of COVID-19 basically revolves around treatment of the acute phase. Whether it is steroids, anticoagulants, these are all, and antivirals, these are all focused in the first 2 to 3 weeks of the COVID management. Longitudinal studies, how to address residual abnormalities in COVID function, lung function, and CT abnormalities, these are not yet studied. There are certain clinical trials which have been started, both with nintedanib and pirfenidone, but the results are not out yet. These drugs at present, as I mentioned earlier, do not figure in any of the guidelines, although in practice, not only in India but elsewhere, physicians have jumped the gun more out of desperation, and there is a widespread use of antifibrotics in prevention of post-COVID fibrosis, although this is not supported by evidence. Now, if we don't have direct evidence in COVID, do we have indirect evidence? For that, we need to consider similar diseases. COVID-19 causes ARDS as the most devastating pathology. ARDS occurs because of diverse etiologies and has a similar pattern of an initial exudative phase followed by a fibroproliferative stage and then leads to end-stage fibrotic lung. ARDS has been studied extensively over the last 2 decades. There are biopsy studies, autopsy studies, and it has been shown that lung function in survivors of ARDS is impaired mildly. However, it has also been shown that although there are abnormalities, later on these abnormalities do not progress. So 5-year study where it was these patients were followed up, majority of patients had normal or near normal spirometric results. There was evidence of fibrosis in CT, but it was non-progressive. So that is one reassuring feature in ARDS, that although there are residual abnormalities, the abnormalities do not progress. So it is a one-time damage that occurs in ARDS. If we look at specific cause ARDS, the nearest that we have is influenza-induced ARDS. Influenza-induced ARDS has also been shown to lead to spirometric and radiological abnormalities, which are usually mild, and these tend to improve over time. These may persist on CT scans like septal lines and pericameral bands, even traction bronchiectasis, but generally these are of no consequence, and again these do not progress. The coronavirus, which is currently affecting the mankind, is Corona 2. Before that, the coronavirus 1 has already struck mankind and caused 2 similar syndromes. One was the severe acute respiratory syndrome of year 2002 to 2004 and the Middle East respiratory syndrome MERS 2012 to 2015. These 2 were involved. These involved a few countries in a localized way, but there was substantial mortality because of ARDS. And patients who survived ARDS in these syndromes, they had a reduced quality of life and pulmonary function sequelae. However, again, similar to the experience in ARDS of other etiologies, it has been found that the abnormalities which are induced in the acute attack of SARS and MERS these have not progressed. And these tend to improve over time. So if we summarize the evidence from the ARDS studies, how ARDS affects lung later on, then decreased quality of life and exercise capacity limitation are long-term consequences, and we know that these would happen in COVID-19 also. However, the pulmonary function abnormalities, spirometry and diffusion capacity, these are mostly mild, and these recover with time, returning to normal in most patients. So that is one reassuring thing, that it's very unlikely that the lung function abnormalities in COVID-19 would progress with time. Secondly, the imaging modalities, CT, these show mild degrees of interstitial thickening and traction bronchiectasis and mechanical distortion in ARDS of other etiologies. But there also it has been found that this does not tend to progress. So the clinical impact and the physiological mechanical changes in lung are non-progressive and
I think we've lost contact.
Yes, sir.
Yes, I think, sir.
But possibly this was also the last slide.
Yes, yes, sir.
So if you can contact him on phone and tell him to cut his video off, stop his video.
I think we got disconnected, sir, actually.
Yeah. You can contact him on phone and check with him.
Yes, we are trying that one, sir.
Right. And in the meantime, should we, since that was the last slide, should we go ahead with Dr. Ankit's introduction?
Yes.
So if you can put that up, we'll go ahead with Dr. Ankit's introduction. But I must conclude by saying that the talk by Dr. Chhabra was extremely enlightening, and his experience and knowledge just shines through the presentation completely.
So this is
I'm honored to introduce Dr. Ankit Ganatra. He is MBBS, FCPS in medicine, fellow in rheumatology and immunology, specialist in joint, muscle, and rheumatic diseases. He's completed his post-graduation in internal medicine from College of Physicians and Surgeons, Maharashtra in 2016. And he pursued fellowship in rheumatology and immunology from Kenisha Rheumatology Care, Mumbai in 2019. And presently associated with AARIRA Medical Center and Dr. Ganatra Hospital. He's associated with the functioning of various professional bodies related to rheumatology and immunology. And during his tenure as fellow in rheumatology, he has experienced in treating more than 8,000 patients with rheumatoid arthritis, osteoarthritis, osteoporosis, Anki-Spond, SLE, scleroderma, and other complicated autoimmune diseases related to lungs, pregnancy, etc., which is an extremely wide experience, I must confess. Dr. Ankit has successfully learned and mastered the procedure of joint injections by treating more than 300 patients, presented papers pertaining to complicated autoimmune disease in various national conferences, platforms, the article presentation on Anki-Spond at various national and state level platforms, article presentation on lupus-related complicated pregnancy at national platforms, and case presentation on vasculitis and related complications. Dr. Ankit, we are honored to have you and are awaiting your talk and listening very carefully to your knowledge and experience coming through. Thank you very much. Over to you. You can share your presentation, sir.
Sure, sir. Thank you. Thank you for this introduction, sir. Yes, sir. Is it visible?
Yes, it's visible.
yes, sir. It's visible.
Okay, my today's talk is managing cytokine production in COVID-19. We are all accepting the fact that COVID-19 has uh, stuck us very hard in last 1.5 years. Started in China back in 2019 December, and then it arrived in India March 2020. And since then, we have been fighting against it. So my today's talk will be on COVID-19 phases, and then we will go on to how it develops the cytokine storm. What are the guidelines to treat the COVID-19, which has been which has been given by Infectious Disease Society of America, and then we will talk about the evidence of the JAK inhibitors in COVID-19 as it has been approved by FDA, US FDA. In terms of baricitinib, and now we are coming up with the tofacitinib, the repurposing of the drug for COVID-19. Let's start with the 40 years with the coronaviruses. It was found between 1960 to 1970, and then there was the first international symposium in Wurzburg in 1980, and over a period of time, it started hitting the human being back in between 2000 to 2002 to 2005 in terms of SARS, and then between 2012 to 2015 in terms of MERS, and then in later part of 2019 we were hit with the SARS-CoV-2. What are the COVID-19 phases? COVID-19 phases are usually, we have been describing in 3 phases, and more than 80% of the people are developing only flu-like symptoms, but 15% also develop the shortness of breath, which is called as pulmonary phase, and out of those 15% people, 5% develop the ARDS and cardiac failure, and it's painful to say that more than 50% of those succumb due to ARDS and cardiac failure. So, how an immunity be reinforced and hyperinflammatory damages can be avoided? So we have to understand the immunopathology of the COVID-19. The first phase, the virus entry, and that's when the person, in first week, the person usually develops the routine flu-like symptoms. And that's when the innate immune response come into picture with first cytokine wave, and that is the time we would like to treat the patient so that he does not develop the immune deficient state. But somehow, because of if I'm talking about the Indian population mentality, they would not talk about this illness. They would run away, and that's when they develop the immune deficient state, and that is when the cytokine storm come into picture, which is a lethal second wave. So basically, COVID-19 induces both impairment and hyperactivation of the immune system. Early viral clearances by IFN type 1, which is a key to prevent further viral replication, T-cell exhaustion, and the cytokine storm. During the first phase itself, with the timely administration of the treatment will reduce the viral load and avoid the hyperinflammation. So this is the kinetic and intensity of the antiviral response. In mild to moderate disease, the viral load is which is when the viral load starts rising, but the type 1 IFN response is such high that the inflammatory cytokines will not take much of the person's, it will not come into picture in such an extent. But if the treatment will not be started in the early phase itself, then the viral load will increase, and then the inflammatory cytokine will come into picture, and that is when the cytokine storm will start. So it is a very complex immunopathology of COVID-19, but I would like to simplify it. In patients with severe COVID-19, the lymphopenia and drastically low CD4 plus T cell and CD8 T cells, B cells and NK cells, as well as the reduced monocytes, eosinophil and basophils will be seen. Additionally, NKG2A on cytotoxic lymphocytes, including NK cells and CD8 plus T cells, are upregulated in patients with COVID-19. Patients with severe COVID-19 will exhibit the elevated serum levels of pro-inflammatory cytokines such as IL-6 and IL-1B, as well as IL-2, 8, 17, GCSF, GM-CSF, IP-10, MCP-1, MIP-1 alpha, which is also known as CCL3, and TNF-alpha, and tissue necrosis factor as well, and which all together will be considered as cytokine storm. The hyperinflammatory response that will rapidly progress, and it will definitely increase the risk of death. Intervention is to aimed at modulating the inflammatory immune response by reducing the toxic cytokine levels, which will improve the outcome in the treatment of COVID-19 pneumonitis. The approach is well established since the publication of Recovery that lead to the usage of dexamethasone in admitted patients. So this is the infectious disease Association of America guideline in 2021, where they have clearly stated that with mild to moderate disease, we do not need corticosteroids or any of the monoclonal antibodies. With hospitalization, with the no need of oxygen supplementation, there is a minimum evidence where you will be succeeded with the corticosteroids. But yes, they have recommended, they have suggested the use of glucocorticoids, where you see the oxygenation is going down, going below 94% on room air, and person needs a mechanical, either need the mechanical ventilation or the high flow oxygenation. But in any case, the tocilizumab is not clearly evident to be used. Even in recent times, the Roche, the only pharmaceutical company which has been manufacturing tocilizumab, they have also said that it has not met the endpoint in terms of survival. Yes, the remdesivir can be used when the patient is hospitalized and patient is in septic shock as well as on ECMO. There is some amount of evidence in patients with the non-critical disease with SpO2 less than 90%, 94% in room air. Recent advances, what we have been following is baricitinib as well as the remdesivir. Baricitinib is a small molecule JAK-STAT pathway inhibitor. They have said that it can be used in non-critical disease where the oxygenation is less than 94% on the room air, but there is no sufficient data on for the patients who need mechanical ventilation or in septic shock and on ECMO. So currently, I would like to talk about tofacitinib, which is another small molecule which has been came into picture back in 2012 for the treatment of rheumatoid arthritis, and it came in India back in 2014. It is a selective JAK inhibitor for JAK1 and JAK3, and it has some amount of effect on JAK2 as well. And it also blocks the signaling from IL-2 as well as IL-4 and IL-6 and IL-11 as well as interferons. So what is the repurposing of tofacitinib? There are 4 Janus kinase JAK receptors present on the surface of immune cell. It will rephosphorylate and then activate the signal transducers and activators of the transcription, which is states, which in turn modulate the expression or gene expression responsible for the production of cytokines such as IL-1, 4, 6, 7, IL-9, 10, 11, 15, 21, 22 as well. Tofacitinib is a JAK-STAT inhibitor, potent immunomodulator approved for the second-line therapy of several autoimmune diseases. By blocking this pathway, and serum levels of these cytokines are significantly reduced as well. But it is important to note that JAK-STAT inhibitor do not have any effect on IL-1, 17, 18, TGF-beta, as well as tissue necrosis factor. So if we talk about the inflammatory pneumonitis, which is caused by COVID-19, more than 50 cytokines are involved. And in that case, tocilizumab, which is only an IL-6 inhibitor, as well as anakinra, which is only an IL-1 inhibitor, compared to that, tofacitinib is more reasonable to use as it has broad spectrum at the cytokine production inhibition. There was a study done in Mayo Clinic with 326 patients were taken with the COVID-19 diagnosis. Out of those, 269 developed the COVID pneumonitis. There were approximately 51% of the patients treated with the tofacitinib, out of which 16 expired. 58 were only treated with tofacitinib, and out of those, only 5 expired. 4 were treated with tofacitinib and tocilizumab. As in August 2020, it was told by FDA tofacitinib and tocilizumab both can be used, and out of those, only 1 patient expired. In those out of 138 patients, 67 patients were only with the dexamethasone, and out of which 8 expired, and 9 were treated with dexamethasone as well as the tocilizumab, which is IL-6 inhibitor, where only 2 were expired. Compared to that, 48% were treated with only dexamethasone. They were included in the group where they were only to be treated with dexamethasone. 30 were expired, and 129 dexamethasone only 29 were expired, and 2 were treated with dexamethasone as well as tocilizumab. Okay. Let's talk about the tofacitinib alone or with dexamethasone or dexa alone. That is what I have shown in the pictorial manner. Total of 44 patients were expired, and 14 people were in the tofacitinib, while 30 people were in dexamethasone group were expired. The proportion of the death amongst the tofacitinib and dexamethasone group were respectively 10.14% and 22.90%. It represents that 70% reduction in the in odds of dying among the tofacitinib group compared to dexamethasone group. You can see the survival benefit. Survival rate is more than 1%, increment in 1% with the tofacitinib group compared to dexamethasone group. Comparing small molecule tofacitinib as with the dexamethasone in head-to-head manner, then the hypoglycemia is the common problem with the dexamethasone group, which probably require insulin coverage while on treatment, where the tofacitinib does offer the added advantage of metabolic neutrality. Lack of hypoglycemia and inducing the catabolic state are significant benefit in an obese, critically ill and population. There was a research article where the JAK inhibitor and type 1 interferon ability to produce favorable clinical outcome. It was presented by Walls et al., where the Janus kinase inhibitors, JAK inhibitors, and type 1 interferons have emerged as the potential antiviral candidate for COVID-19 patients due to their proven efficacy against the disease with excessive cytokine release, and their direct antiviral ability against the viruses include the COVID-19. Of 733 research studies, they have included 4 randomized and 11 non-randomized trials, and 5 of the studies were unpublished. They have concluded that the people with the Janus kinase inhibitors significantly reduced the odds of mortality. There was a significant reduction in the morbidity as well as the ICU admission, and there was an increased number of hospital discharge over a period of time. compared to standard treatment group, which is with the dexamethasone, remdesivir, or other drug. There are few ongoing trials at present. There is a multi-central randomized double-blind trial. The phase 1 trial is over currently, and they have shown the promising result with the tofacitinib. And there is another trial, TOFA-COV-2. They also have finished the phase 1 trial, and they have shown the significant reduction in the death rate as well as the morbidity. So tofacitinib in COVID-19, what is the role? It reduces the inflammation as well as the inflammatory pathology by inducing the immunosuppression. It has a broad spectrum anti-inflammatory profile. There are few published evidence which favor the repurposing of the drug. Survival benefit with COVID-19 hospitalized patient has improved. It has a metabolic utility as well. Guidelines recommend the JAK inhibitors for COVID-19. I would also like to share my own experience with tofacitinib as well as the newer JAK inhibitors such as baricitinib, where I have treated some of the patients of COVID-19. The numbers are obviously pretty low, as I have treated 10 patients with the COVID-19 with tofacitinib and 15 with baricitinib, and I can say that I have seen the decent number of results. Thank you. I would like to take the questions.
That was extremely enlightening, and Dr. Ankit, the question hour session would be at the end, and we have one more talk left. I'm going to share screen and talk very briefly on PAH and COVID in the pediatric population, and just enlighten everyone about pediatrics and COVID-19 infections. So children have been relatively spared from severe COVID-19 related illnesses and represented 1.2% of the caseload in Italy, 2% in China, 5% in US. The statistics are between 2 to 6% currently of the total number of patients. Now, prevalence of COVID-19 in PAH patients, 12% prevalence of PH among hospitalized patients with COVID-19 in a non-ICU setting. Patients with PAH have similar incidence of COVID-19, and the incidence is 2.9 per 1,000 patients. And the PAH patients affected by COVID-19, 50% hospitalization and 12% mortality rate. Now, what happens in children when it comes to heart and COVID-19 and heart related to lungs and pulmonary hypertension? So children differ when it comes to COVID-19. In adults, there can be myocarditis, infarction, cardiomyopathy, cardiogenic shock, acute cor pulmonale, or arrhythmia. But in children, there is myocarditis, myocardial dysfunction, and coronary artery involvement. What is the coronary artery involvement in children with COVID-19? They get coronary aneurysms. So this is what we will talk about. So WHO, Royal College of Pediatrics and Child Health, and CDC have all come up with their criteria for diagnosis of what is called as MISC, multi-system inflammatory disease. And basically, after 4 weeks of COVID infection, which could be an asymptomatic COVID infection, I'll go through the WHO criteria. Rash or bilateral non-purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, features of myocardial dysfunction with echo findings, including echo findings and NT-proBNP elevated and troponin 1 elevated, evidence of coagulopathy, gastrointestinal symptoms being the predominant clinical presentations in pediatric population, and then the clinical markers as ESR, CRP, procalcitonin could also be elevated. But since this presentation that is referred to as multi-system inflammatory disease in children, or MISC, is seen 4 to 6 weeks later, RT-PCR test is usually negative in such presentations, and because it's 4 to 6 weeks later, and the antibody test is usually positive. The coronary involvement is similar to that seen in Kawasaki disease. It may be a manifestation of incomplete Kawasaki or Kawasaki disease shock syndrome. Children with multi-system inflammation in children, also referred to as PMIS in UK and Europe. Children with this have persistent fever after 4 weeks, asthenia, diffuse erythematous rash, non-purulent conjunctivitis, prominent gastrointestinal symptom. The only presenting symptom 4 weeks after acute illness of COVID would be or could be pain abdomen. Mucosal changes and peripheral edema, which along with rash and conjunctivitis resemble clinical characteristics of Kawasaki disease. This is how a child would present. So there could be tongue involvement, it could be extremely red, lips could be extremely red, this is called a strawberry tongue, non-purulent conjunctivitis of eyes, polyerythematous rash, and involvement and skin peeling around the nails, rash again, which is seen in variety of forms. And what is the difference between a child getting COVID infection, which is on the left side of your screen? The main response is the interferon response, and the IL-6 or chemokines are seen. They are relatively subdued when it is a milder disease. But when it is severe disease, including MIS-C, which can be devastating, there is slower viral clearance. The IL-6 and chemokines are the predominant response, and it is a delayed IL-6 response, which peaks beyond the level of interferon. So basically, it is a patient who's been exposed to COVID and 4 to 6 weeks later gets persistent fever and clinical features of Kawasaki or clinical features of shock or clinical features of heart failure. And on lab assessment, apart from various markers, we have CRP, ESR, procalcitonin, D-dimer, fibrinogen, ferritin, interleukin 6, cardiac biomarkers are done, ECG, echocardiogram are done, and the patient is labeled as multi-system inflammatory disease in children. And this is very important. A lot of studies have been done, echocardiographic findings in pediatric multi-system inflammatory syndrome associated with COVID-19 in children. They have shown there is dilatation of the coronary artery as seen in the right coronary here, the valvulitis in form of mitral regurgitation, pericardial effusion, which is usually mild, myocardial systolic dysfunction, severe LV dysfunction, and diastolic dysfunction in 100% of the patients. This is the left coronary artery, this is the right coronary artery, this is how we see them. And this cardiac study involvement showed there is systolic dysfunction, diastolic dysfunction, LA strain abnormal, and RV strain abnormal. And typically, coronary involvement and dilatation would be seen in about 4 to 6% of the patients with this. This is how the coronary aneurysms look like in these patients. Just to let you know that this is a devastating disease seen in children. So, let's go back to pulmonary arterial hypertension and COVID-19 individuals, especially children. And since there can be pneumonia, other infectious complications of COVID-19 may happen, worsening of pH symptoms may happen, and a complex mechanism through which involvement of lungs may happen. Endothelial dysfunction is the key to initiate the cascade of events leading to ventilation perfusion mismatch, hypoxia, vasoconstriction, pulmonary hypertension, and the COVID-19 causes endothelial dysfunction, diffuse microangiopathy, microthrombosis, and ventilation perfusion mismatch. So any child with existing pH or newly diagnosed pH should be tested for COVID-19 after the pandemic, in the post-pandemic era. New diagnosed pH screening for COVID infection in terms of rapid antigen or antibody test if it's later on, evaluation of pH as per guidelines. An established pH patient can be managed on teleconsultation, repeat tests may be required, apart from monitoring of saturation, etc. In non-critically ill patients, if fever persists and saturation drops, consider admission, ECG, X-ray, echo, chest CT, and other lab tests which are routine, including procalcitonin, may be important. But if the patient presents 4 to 6 weeks later, the tests may involve specifically the cardiac tests more than anything else. In critically ill patients, signs of MIS-C have to be looked for. Multidisciplinary team is involved. The treatment is IVIG 2 grams per kg. Low-dose steroids can be given. Anticoagulant remdesivir may be considered. It is essential to continue specific pH therapy in children even during COVID-19 illness unless changed by their provider. Sildenafil, bosentan, ambrisentan, tadalafil are commonly used therapies for pulmonary hypertension which have shown beneficial effects by shifting blood flow to adequately ventilated lungs. And impact of COVID-19 on pH care in children has significant impact on the pH care in children. 97% centers in US are offering routine virtual visits and decreased routine diagnostic procedures to prevent risk of transmission at pH centers. So, what is the response of pH community to the pandemic? pH community is adjusting in real time and using the best clinical practices in children with pH. pH programs have adopted to protocols for management of pH without increasing the risk of exposure to or transmission of COVID-19. Basic guidelines of mask wearing, hand sanitization, and social distancing are continuing, and close monitoring of patients. Appropriate therapy have to be continued. There is no evidence to suggest that patients with pH are at a higher risk of being infected. In fact, they might be protected, and there is strong evidence to show that pH can be worsened with pneumonia or other infections and complications of COVID-19. With that, I end this presentation and I open the discussion session, and we already have several questions. I will go through them. So I'll take questions for Professor Chhabra first. One very interesting question, sir, for you is nintedanib versus pirfenidone. What should be preferred in post-COVID fibrosis?
Let me answer this first with a rider that none of the two is approved for post-COVID fibrosis. So if at all one wants to start, it has to be in a clinical trial mode. So if you're doing a clinical trial, definitely go ahead and use. But there are no established protocols for use of nintedanib or pirfenidone in post-COVID lung at present. Having said that, pirfenidone may be a little safer compared to nintedanib because the risk of bleeding that is associated with nintedanib that may be enhanced due to the coagulopathy that is part of the COVID syndrome. So that way pirfenidone appears to be a safer alternative to nintedanib in COVID-19. But one must understand that these are not drugs which are going to reverse fibrosis. Not all patients would require these drugs. So one has to be very careful which patients one is going to use. So not universal therapy that patient recovers from acute COVID pneumonia and then you put these patients on antifibrotics.
Right, sir. There is, in fact, the same question has been asked in various other forms also. And there are a few other questions. How is COVID-19 causing pulmonary fibrosis? I think you highlighted, but if you could summarize once again for our audience.
Well, there are two mechanisms. One, any inflammation and injury to a body part is followed by fibrosis. That's the normal process of healing. Like we get tuberculosis and we are left with large areas of scarred lungs. So one is that extensive pneumonia is followed by extensive fibrosis. The other is that when the fibrosis becomes progressive, that is, doesn't stop as a repetitive process, but itself becomes a progressive phenomenon. So that becomes a disease. So that is the concern in COVID, that it may be leading to a progressive fibrosis. So one-time damage is expected because of any tissue injury. That is repetitive fibrosis. But if that progresses, then that is the other, and there is a theoretical basis it may progress. Although epidemiological evidence is not there, and if you compare it with the earlier avatars of corona, the MERS and the SARS, there also we did not get a progressive fibrosis. So early days yet to say whether COVID-19 will lead to a progressive fibrosis. But yes, a repetitive fibrosis exists, that occurs.
Right, sir. One more question coming up for you is, does sleep apnea affect PAH at any stage?
For me? Oh yes, sleep apnea definitely leads to pulmonary hypertension. It's one of the contributory factors because hypoxemia and chronic respiratory acidosis that occurs with sleep apnea. And then most of these patients are obese, so they also have a obesity hypoventilation syndromes. They are perennially hypoxemic and acidotic. So both factors which would lead to an increase in the pulmonary artery resistance and pulmonary artery pressure. So that affects the prognosis of pulmonary hypertension adversely.
Sir, there is one more question. Would you like to take this one? Who should be the right candidate for anticoagulants in COVID?
There's a lot of debate on this as to what is the degree of coagulation that is. One thing is, which everybody agrees universally in all the guidelines, is that patients have got a moderate degree of COVID involvement, which means the patient is dyspneic and is having a hypoxemia, saturation less than 94%, he is a candidate for anticoagulation. Now the issue is therapeutic coagulation, an intermediate or a full anticoagulation. There are people who advocate using D-dimer levels as a guide to anticoagulation, and there is one school of thought which says that D-dimer levels above 2500 or rising levels call for a full anticoagulation. Another school of thought, and most of the hematological societies and the thrombosis societies, they agree that we should not go in for full anticoagulation, only give intermediate coagulation for severely involved patients and therapeutic anticoagulation for mildly involved patients. So it's a prophylaxis more than a full anticoagulation that has been advised. And using D-dimer as a guide again is debated.
Right, sir. There is one question for Dr. Ankit, role of tofadose in COVID situation. Would you like to take this, Dr. Ankit?
Yeah, sure. I'll take the question. I already explained the situation.
Yes.
Tofacitinib itself is a small molecule. It's a JAK-STAT inhibitor drug. So it works on multiple cytokines, and that's how the cytokine storm can be reduced, or cytokine storm can be prevented. Where during the early stage, when you see the CRP has been rising, or when you see the lung is getting more involved in the second week of the disease, and that's when I would like to introduce tofacitinib, even in the OPD days as well, because I see the patients more on OPD days where they are infected with COVID-19, and by second week when I see there is a reduction in the oxygenation, I would like to introduce tofacitinib. But again, coming back to the question, it's all given in the slides where it works. It is a broad spectrum medicine where it works on multiple cytokines, and that's how it works in COVID-19.
Right. Professor Chhabra, there's a question for you. Can you suggest, is post-COVID fibrosis reversible or not?
In our experience, majority of the shadows that we see in acute phase, they tend to resolve. Now, these shadows that we see in acute phase represent consolidations. They represent microthrombi of the pulmonary vessels and fibrosis and alveolar congestion. So most of the findings would resolve after 1 to 3 months, and we have documented this with some of the images I had shown. The degree of scarring that a patient is left with is definitely less after a few months than it is there at the end of the acute phase. So by and large, patients of COVID-19 would tend to heal over time. So that is one reassuring feature about COVID. But so far, we don't have evidence it's a progressive disease, both lung function and the imaging features.
That's encouraging that it's not progressive. One more question for you, sir. How early do you start glucocorticoids in COVID pneumonitis?
That is a very vital question. The disease has a viremic phase and it has an inflammatory phase. The viremic phase is typically in the first 7 days. Now, if we use steroids too early, then there is evidence that one may actually be harming the system. Because the body has to fight the virus, and we give 1 week to the body to fight the virus. Second week is where the complications start. And that is where the pneumonia and the cytokine storm starts. So if a patient is not resolving by end of first week and develops hypoxemia, that is the time to intervene with corticosteroids. So the guidelines are very clear. Any person who has got a saturation of less than 94 is a candidate for corticosteroid therapy. And greater the severity, greater is the dose that is given. In fact, there are papers which suggest that a pulse steroid therapy of 250 milligrams methylprednisolone given daily for 3 days has an advantage over lower doses of steroids. Dexamethasone was the original steroid that was shown to have a mortality benefit. In the recovery trial, 6 milligram per kilogram, 6 milligram dose was given, and that reduced the mortality. So indication is moderate disease, saturation less than 94%, not before that.
Right, so very interesting question. Would you use pirfenidone in moderate COVID disease to prevent fibrosis?
Unfortunately, the drug pirfenidone does not have this virtue. It is not a prophylactic. It cannot prevent fibrosis. If it could, then we would be using it in tuberculosis. You know, we are left with destroyed lungs. If we could prevent fibrosis, that would be a wonder drug. It only retards the progress of the fibrosis. It doesn't reverse fibrosis. So it cannot be used as a prophylactic to prevent fibrosis.
Right, and tofacitinib safety in usage in COVID-19 patients. I think, Dr. Ankit, this is for you. Is Dr. Ankit there? You're on mute, sir.
Yeah, yes, I'm back.
Sorry. So, tofacitinib safety and usage in COVID-19 patients. You think this is your question? You would want to take this on?
Sorry, sir, I did not get your voice.
I hope I'm not mute. So
No, you're not mute.
Tofacitinib safety and usage in COVID-19 patients.
Tofacitinib it is a complicated drug when it is used for a longer period of time, which we use in rheumatoid arthritis or in ulcerative colitis, before starting the drug we do the MANTU and we do the TB fever and cold to look for the TB profile, latent TB as well. But for the short period of time and for the there are pretty conclusions that there have been studies which showed that there is not much of complication because due to short period of for a period of 2 to 3 weeks when we are using tofacitinib, it is pretty safe drug.
Right. There is a question, COVID-19 patients can develop PAH in long term. Yes, definitely they can develop. And then there are questions, how to choose between macitentan and ambrisentan. So this is a question which is more clinically related to non-COVID pulmonary hypertension, and this can be taken care of. Method of dilution and administration of remdesivir and tocilizumab. Please, Nutan, track the person who has asked this question and we can send a write-up to them about this. I think there is one more question. Does HCQ help reduce cytokine storm as CRP level and fever levels found to drop after HCQ plus steroids? So there is nothing proven in terms of HCQ reducing cytokine storm. We know that very clearly from large number of studies. The combination of steroids might be helping, but again, steroids have to be used at the right time. I think we are going through the last few questions. There's a question Dr. Bindu has asked: a surgeon with severe PAH on tadalafil and ambrisentan, can she continue to work in this pandemic or take leave? Ideally should not be exposed to COVID-19 because this is a very difficult situation. Dr. Ankit, do you have experience using Selexipag?
No, sir. No, I have no experience.
Okay, so there is a question related to Selexipag role in PAH. Is it helpful in survival? Not proven to be helpful in survival. ERAs and phosphodiesterase inhibitors have helped survival. Selexipag is mainly used in connective tissue disorders. IV has been more helpful than oral, but it is the oral form which is most commonly used because it was designed as a prostanoid oral medication with the lesser side effects, gastrointestinal side effects, compared to the Beraprost, which is the other. Last question. A patient having sildenafil 20 mg TID having hypotension, is it possible or not? Unlikely. If it's an adult patient, this is not a very high dose. You have to look for cardiac causes or other causes that just the sildenafil itself is causing the hypotension, but you could reduce the dose and also check. So with that, we end the question answer session. I thank tremendously our speakers, and I wish each one of the audience a safe time ahead for them and all their family members, and stay away from COVID while taking care of the patients. Please don't acquire the disease yourself. And I hand over to the team of MNS, and they can conclude the session today.
Thank you, sir. Thank you for all the guest faculties for this excellent presentation and the enlightened the knowledge what you have given to us. Only the and to see 2 slides only, sir. Sir, regarding this the COVID-19 and this your pulmonary hypertension. So we look for an exclusive particular support for this world-class international quality medicine. Like we have the Fabilo, we have launched for this COVID-19, and PH for the brand of sildenafil, and the Perfenidone, that's the brand of Pulmofave. And recently we have launched the tofacitinib, that is Tofadose. Right? We may be the young player, but our drive and enthusiasm are the best in associating with you. Thank you. Thank you for joining. Sir, Dr. Kohli?
Yeah, we conclude the session today. I thank the audience. I thank Professor Chabra, Dr. Ankit for their esteemed talks which have enlightened us thoroughly. I thank Mr. Mondal, and I thank the team which is coordinating in the background for Health Visions, all the coordination and IT work they are doing. It has been a tremendous learning experience. Wish everyone a safe time ahead, and good night.
Thank you. Good night.
Good night, sir.